Good morning, good evening. Welcome to everybody. Thank you so much for joining us for this very exciting discussion today. And I know we need to give another maybe 1 or 2 minutes for other colleagues to join the call. But while we do that, I want us to pause and reflect a bit. So I want to share with us a short documentary that really brings us face to face with the urgency of our shared mission to protect the lives of women and children across the African continent. We know that we are in a world where we see, the aid architecture shifting, and we know that health systems are under strain. And we cannot afford to stand still. We need to protect the progress, but we also need to do more with fewer resources. So this documentary that we are going to show captures the urgency behind our advocacy for mothers and children across the region, but also to reflect on the changing ecosystem and the need for us to act boldly, but also act collectively to ensure that we end preventable deaths of mothers and children. So I'll leave you with that for just a minute, and then we'll come back and start the conversation. So thank you so much and welcome.
Maternal, child, newborn health issues have already been a priority for a number of countries. Quite a number of countries, especially within the Africa region, are off track as far as reaching the targets are concerned. When we focus on Africa region, we realize that the decline is not as much as was expected or should have been. And so the trajectory or the decline that we are seeing may not get us to the SDGs. So for instance, for maternal mortality, the current mortalities, Africa contributes about 70%, just one region. For the newborn mortalities, indeed it has come down, but still we have close to 50% from Africa region. I think the exact figure is 47% from the Africa region. So one of the key advocacy issues for this year's World Health Day and the year-long campaign that is going to follow is to reprioritize maternal, newborn, and child health, and to get governments, ministries, everybody involved in the business of maternal, newborn health, because we realize that it cannot be done or it cannot be addressed just at one level. So there's a need to address it at all levels, from the government, at facility level, all the way to communities, because communities, families also have a strong role to play.
Based on the evidence that we have, countries need to accelerate action and progress in order to meet the 2030 targets for maternal health, newborn health, and child health as well. So the agenda to accelerate needs a strong advocacy strategy. So as the Africa region, we need to think through what the investment is going to be to match the ambition that we have, what the political will is going to be in order for us to meet the 2030 targets, but we also need to think about what partnerships we need to advance this agenda.
Working out an advocacy plan jointly with the different contributions of the different partners is essential in terms of bringing these plans to fruition, but also ensuring that we are also working as one body and not working in silos.
Advocacy is really key. I think at country level, we really need to get the attentions of the leadership, senior leadership in the government, so that we can, advocate, because really our politicians need, a repetitive, kind of making sure that MNH is integrated into the policies, international policies. So, by advocating and, changing those commitments into actions can usually, progress the, MNH services in different countries like Somalia.
I'll mention three things that are important. One, investment is very important. So investment in a way that that responds to the acceleration agenda that we have at the country level is critical. But secondly, is strengthening the political will so that it translates into actual investment, actual implementation of policies. That is also going to be very critical. But then the other bit is we need to think about what the evidence is telling us, and we need to become restless as a region so that we respond to what the evidence is telling us.
Women's health is such a key driver of economic development. It's a very difficult thing to unpack, but once you actually entice leadership and entice influential leaders to know that if you improve the quality of life of women, you are positively impacting on the economy of our country, then maybe the advocates will be much stronger. There is progress that we are making, we wish you can do more and much faster.
Colleagues, welcome to this very insightful conversation. Allow me to start the conversation here. I think we have reached a critical mass of partners. So welcome again. Thank you so much for joining us for this regional advocacy dialogue that is focusing on rethinking the future of maternal and child survival in Africa, but also rethink how we talk about it or think about it within the changing aid landscape. Now, I'm delighted to be moderating this webinar today. And for those that are seeing me for the first time, my name is Esther Nasike. I am an advocate for the health rights of women, children, and adolescents. And I am also the co-chair of the Advocacy and Accountability Working Group for Every Woman, Every Newborn, Everywhere. And I do that together with UNICEF and Partnership for Maternal, Newborn, and Child Health, that is PMNCH. So as we start this meeting, I would love for you to add in the chat where you're joining us from and which entities you represent, so we know who you are and where you're joining us from. But while we do that, I also want to share the ground rules. I hope we shall all remain muted unless called upon to speak so that we minimize the interruptions during the discussion. But I also request us to remain actively engaged. So feel free to ask questions, to share experiences, and we can use the chat to have that done. And now I'm going to request my colleagues, if you could share with us, yes, thank you. Just take me to the next slide. For those of you that might not be very familiar with PATH, I'll just tell you a bit who we are. So PATH is a global team that is dedicated to achieving health equity so all people and communities can thrive. And together we are driving public health solutions that meet the most pressing needs of families, communities, and countries. And today specifically, we are going to be talking about maternal, newborn, and child health, specifically within the Africa region. So PATH is a global team that works in 70 countries around the world, but our advocacy and policy portfolio focuses primarily on the African continent. And we recently launched our Center for Advocacy and Policy, which brings together health solutions to scale through evidence-based policy and practice. And we also leverage our technical expertise and, of course, deep relationships with countries and global partners to design and shape impactful policies and ensure, effective implementation, and in a way that really changes the lives of people and the community at the community level. And so in terms of this conversation, like I've already mentioned, our focus is on maternal, newborn, and child health. And why do we think this conversation is important? First of all, we have less than 6 years until 2030. And we also know that in terms of the current trends, 4 out of 5 countries, which is 80% of the countries, are most likely not able to achieve their national maternal mortality targets. But we also know that quite a number of countries are off track in terms of their neonatal mortality targets, but also the under 5 mortality targets. What does that mean? That means we need urgently to accelerate progress. But we also know that most of these deaths are preventable. So we need to talk about accelerating progress to reduce preventable deaths of mothers and babies. Now, in the last 6 months, the financing landscape has shifted drastically and shifted in a way that has an impact on many African countries. We have seen, a decline in terms of donor financing, but also we have seen, constraints in terms of domestic financing at the country level, because countries are facing challenges in terms of debt repayment, low tax base, that they are not able to collect enough resources to be able to meet and cover the priorities that they have defined for women and children. This conversation is not starting now. We know that during the World Health Assembly, we had some of these conversations, but not everybody is at the World Health Assembly. We also, as countries, need to come back in the region and think about how we meet the commitments that we have set, but also how we respond to the challenges that we are facing now. And during the World Health Assembly, we had leaders calling for the need for us to meet the commitments that have been made, ensure that there is accountability, but also strengthen country-led financing strategies to respond to the need at the moment, but also to increase or strengthen the visibility of maternal, newborn, and child health on the political agenda. And so today, we want to dive in a bit into that conversation and ask the question around what we need to do differently in order to respond to the challenges that we see. We know there are disparities across the African continent, but we also know there are disparities within countries. And so we will be listening from UNICEF, for example, to talk to us about what the performance is like, what the progress has been like in terms of reduction of preventable maternal mortality, but also child mortality. But we'll also talk to country leaders, technical leaders that are defining, the response at country level to tell us what innovations are in place to make sure that they reduce the preventable deaths of mothers and children. So this is the first part of a two-part webinar that we are focusing on. And for this part, our focus is really around financing, understanding the progress that has been made, but also talking about the new partnerships that we need to think about if we are to sustain momentum, but if also we are to reduce or possibly end the preventable deaths of mothers. So in terms of objectives, I'm going to summarize quickly. We want to share the latest progress in terms of maternal, newborn, and child health. We also want to examine the impact of the changing aid landscape on the progress that has been made. And we also want to together, think about the solutions and the partnerships that are needed to sustain efforts, to save mothers and children. So with that, I want to invite our first speaker. And our first speaker is Tomomi Kitamura. She is a health specialist with UNICEF. And Tomomi has been working with the UNICEF Regional Office for West and Southern and Central Africa, specifically in the health and HIV section. She has extensive experience in the fields of maternal, newborn, and child health, and also early childhood development. And Tomomi, we would like you to share with us the latest progress coming out from the most recent reports, the MMR report that was launched in April, but also the UN Interagency Group for Child Mortality Estimation report, so that we understand where are we as a region, but also where are the disparities, so that as we talk about strengthening an advocacy agenda, it is really informed by the data that the normative agencies are providing for us. So over to you, Tomomi.
Thank you so much for having me today. It's such an honor. So today I am going to share some of the latest data on the mortality in terms of mothers and newborns and children. So the overview, today I'm going to start out with the mortality and some of the numbers, and then touch upon the cause of death and key interventions, and then maybe talk a little bit about moving forward. So first thing, the mortality. So I'm going to start out with the maternal mortality. So number of the maternal deaths in Sub-Saharan Africa is almost like 190,000. It's around more than 70% of the maternal deaths worldwide. And this means more than 500 maternal deaths every day in this region. Maternal mortality ratio in this region is 447 per 100,000 live births, highest in the world, but the region succeeded to reduce by 40% comparing to the year 2000. And now to the stillbirths. Number of the stillbirths in this region is around 50% of the stillbirths worldwide. And then the stillbirth rate in this region is around 22 stillbirths per 1,000 total births. It means 1 in 45 babies in this region is stillbirths, and he or she never takes his or her first breath. But the region reduced the mortality rate by 29%. And now to newborn. The number of the neonatal deaths is around 1.1 million in this region. It's around 50% of the neonatal deaths worldwide. Neonatal mortality rate is 26 per 1,000 live births. It means that 1 in 38 newborn babies in this region does not survive beyond first months of life. But region reduced by 34%. And now to the mortality rate for children aged 1 to 59 months, so after the neonatal period. The number of the deaths in this age group is around 1.7 million in this region. It's almost 70% of the children aged 1 to 59 worldwide. And the mortality rate for this age group is 42.9 per 1,000 live births. It means 1 in 23 children in this age group does not survive in this region. And then, but the region actually made a remarkable progress for this age group. The region reduced the mortality rate by 62% comparing to year 2000. Now the under 5 mortality. So the number of the deaths for under 5 children is 2.8 million in this region. It's around 60% of the children under 5 deaths worldwide. The under 5 mortality rate is 68.1 per 1,000 live births. It means 1 in 15 children die before reaching their 5th birthday. And the region also made a remarkable progress by reducing by 50% comparing to year 2000. So that in actually the region, Sub-Saharan Africa, you made a remarkable progress despite the difficult situation, the economic instability. Some countries are touched with the fragile and conflict context, and then also the climate change and so on, that you made a remarkable progress. But when we look at the SDG, the Sustainable Development Goal targets for mortality, how many countries are going to risk at missing the SDG targets? Unfortunately, we don't have data for MUP yet for maternal mortality ratio. So I start with the stillbirths. Actually, stillbirths doesn't have an SDG target. So I'm using the EWNI, the every newborn, every woman, every newborn, everywhere target, which is 12 per 1,000 total births. Globally, the countries marked with green, dark, or light are at risk of missing the target for stillbirths. We have 53 countries in the region, in the worldwide risk of missing, and 43 countries in this region. For newborn, children aged 1 to 59, and children under 5, the countries marked with red or orange, dark or light, or yellow are at the risk of missing SDG target. For newborn, we have, I think, around 65 countries, as Esther mentioned, 42 countries in this region. For the children aged 1 to 59 months, 49 countries globally are missing the target, at risk of missing the target, 35 in this region. For under 5, globally 60 countries are likely to meet the SDG target, 43 countries in this region. So around 70% of the countries globally, around 70% of the countries at which are risk of missing the SDG target are in this region. And when we look at the rate of progress, comparing to 2000 to 2015, which is like MDG's Millennium Development Goal era, that we actually slow the progress for most of the age group but comparing now that how we have to accelerate the progress, comparing to after 2015 to up to now to the future till the 2030, for maternal mortality ratio to reach the national target of 140, we have to accelerate our efforts by 5 times. For stillbirths and newborn, we have to accelerate by 7 times. And for the children aged 1 to 59, it's 4 times more. And then for under 5, we have to accelerate by 5 times. So maybe this slide could evoke your thinking that we may have to prioritize and concentrate more for the age group with the slower progress, with the larger acceleration needed. But for example, but when we look up the age group for 1 to 59, of course, we reduce the mortality rate for this age group by more than 60%. And then we only have 4 times acceleration, but we need the rate of progress by like 18%, which is larger than any of the age groups. So we can't stop the progress for this age group either, even though the progress is faster. Now moving on to the cause of death. I start with the maternal cause of death. Cause of death for mothers, the hemorrhage and hypertension still remain as the top 2 causes for the mothers, followed by the indirect cause, that which include like pre-existing condition like diabetes mellitus for the mothers before the onset of the pregnancy. But it doesn't change so much last couple of decades. And for stillbirths, unfortunately, we do not have enough data to analyze the cause of death. So I'm just going to share some of the information when we have the stillbirths. So half of the stillbirths happens actually before the onset of labor, but another half of the stillbirths happens during the labor in this region. So 1 in 2 stillbirths occurs during the labor. So what does it mean in this region is like when the mother reaches healthcare workers for delivery, a baby is still alive. So that life could still be saved if we could offer the appropriate interventions in this period. And then for children under 5, the top 5 causes actually does not change so much between the year 2000 and then right now. So for in year 2000, the first cause of death is malaria, followed by pneumonia, and the third one is diarrhea. And the last 2 is neonatal conditions like prematurity and birth asphyxia, the baby being too soon or baby being born too sick. And in year 2000, the year 2023, right now, the top 2 doesn't seem to change. So it's pneumonia and malaria. Of course, we reduced like pneumonia by 53% and malaria by 60%, but still the top 2 remain the same. And diarrhea actually reduced by 65% and then allow the prematurity to become top 3. But in a nutshell, that we didn't change so much the top 5 causes of death with children. And then, as you know, the causes of death that we presented here, these could be prevented and then treated with the interventions which are known and then also proven effective, and then with the low cost. What are the key interventions? So that it's just my wish list that we would like to invest more to implement and scale up and then assure the quality. In a summary, the first step of the care we need is the care during pregnancy, like antenatal care, which benefit mothers and then also prevent stillbirths and then also the premature births. And then we also need the care around the time of birth, like the skilled birth attendants. We need midwife to accompany the delivery, and then also in the essential newborn care, like skin to skin contact, like put the baby on mother's chest to provide the warmth, and then also initiate the breastfeeding. The breastfeeding actually prevent the later in life, the pneumonia and diarrhea, childhood illness. And then also when the complications happen, we need to offer emergency obstetric and neonatal care. And then also the care, special care for small and sick newborns when the baby is being born too soon and too small. And then also after the delivery, we need the postnatal care for mothers and the babies, because this is a critical moment that the mothers and babies could lose lives. So we need to keep an eye on those periods. And then also considering the causes of death, that we need to take care of pneumonia, diarrhea, and malaria. And then also malnutrition. We need the care and diagnosis and treatment early enough so that we can treat them. And then also we need the follow-up during the childhood period as well, in order to identify danger signs early enough so we will not lose children after they survive the newborn period. And also we need the preventive services like adequate nutrition, water and sanitation, and then immunization, so that we will actually let the children and mothers survive and thrive. And then actually these cares have synergy to each other, interdependent, so that the I think we could move forward together. But while we know what works, what's going wrong, that we are not reaching the target. One challenges we have is the service coverage. I think the service coverage is not good enough for right now. And then also we have a large disparities within the countries and then also among the countries in this region. The top graph actually shows the proportion of the mothers accompanied by the skilled birth attendant during delivery. There's a large disparities. The lowest coverage for these services is 32%, while the countries could reach like around 100% coverage for this service. And when you look within the countries, comparing rural and then urban areas, that we have a large disparities between urban and rural. The urban is likely better coverage, and the difference between urban and rural could be more than 50%. So that is a large disparities between the within the countries. And then I can actually point out another problem using this graph. Actually, the data that I'm using here may come from the year 2010, because the countries are not able to have the quality data, so that we are obliged to use some kind of old data. So it's also one of the problems that to reach the target for to reduce the mortality rate. Now coming to the child health services, the top graph actually shows the proportion of the children sought cares when they have the symptoms of pneumonia, like cough, fever, and running nose, with healthcare facilities or the provider, the healthcare provider. The disparity is even larger. So the lowest could be 14%. So only the 1 in 10 children reach to the health facility. And then looking at the treatment, when you go down to the bottom graph, this is showing the proportion of the children with diarrhea who were given the ORS, the oral rehydration salts and zinc to treat the diarrhea. It's actually the highest coverage is only 50%. It's a little bit more than 50%. So even though that we do reduce the diarrhea as a cause of death is quite large, we could do a lot more to reduce the mortality. But it's not only the challenge that we have. Another challenge we have is the quality of care. So when even the mother delivered the baby with a skilled birth attendant like a midwife, that the only 50%, a little bit more than 50% of the children benefit from breastfeeding within 1 hour. And then also postnatal care, that's in the middle graph, that only around 60 or 50% of the children and mothers get the postnatal care within 2 days. And then again, diarrhea on your right-hand side, the 40% of children sought cares for diarrhea, and most of them get the ORS, but they don't, only 20% gets the ORS and zinc. And if it's the zinc and ORS, we could reduce the duration of the diarrhea episodes and then also prevent the future diarrhea for several months. So again, if we assure the quality, we could reduce a lot more deaths. So moving forward, in order to implement and scale up these interventions, we would like to invest more for strengthen the health system, putting the primary health care as core, because most of the intervention could be provided at the primary health care level. And then to strengthen the health system, we have a lot of pillars for leadership and governance and community engagement. I think the panelists could talk a lot more. So I will jump into actually the resource mobilization and financing. As an external partners, that we may have to think twice, benefiting from the synergy and interdependence of the cares, the interventions, we could invest more for the health system. And then in the countries, we talk a lot more about like domestic financing and so on. It's easy to say, difficult to do. So maybe we could invest more to support the governments to analyze where we could find more resources, efficiently use them, or even we can support the Ministry of Health with data analysis so they can convince the Ministry of Finance with evidence and so on to move forward. And then the health workers, not only at the hospital, not only at the primary level, we need to probably support the community health workers because they are the key. And then also not only doctors, but also nurses and midwives, they are also the key for survival of children and mothers. And then supply system, of course, we need equipment and medicines, but also we need support and investment for distribution systems so every child can get the ORS and zinc if they need it. And then also the referral system so that we can bring from community to primary to the appropriate level, the mothers and children if needed. And then the health information system, the data could be old, but we need to have the up-to-date data to track the progress and to know the challenges where the vulnerable population is. So that's, I think, what we would like to invest more to accelerate the progress. So towards the end, and this is my last slide, so that we should move forward for every child, every mother, every stillbirth, every child to survive, to thrive. And then we should invest more equitable coverage with quality. And then we have to maybe break our thinking, not to the vertical approach, more for life cycle so that we can leave no one behind. So thank you so much. Over back to you for your patience.
Thank you so much, Tomomi. Fantastic presentation. It is always important that we derive our advocacy priorities from what the data is telling us. So thank you so much for helping us understand what the current progress is looking like, but also where the challenges are. So there is just one question for you, Tomomi. There's one question. Let me just go back to the chat and see where that is. So yes, so someone is asking that service coverage and quality of care, of course, remain major bottlenecks, like you have articulately, presented it. So how can African countries balance expanding access with improving quality, especially at the primary health care level? I don't know if you could just respond to that in 1 minute.
Okay.
How do the countries balance? Yes.
Okay, yeah, it's a difficult question actually. So I think the first thing that we have to probably move away from the vertical approach that this is for malaria or this is diarrhea and so on, but we have to probably think more the health system strengthening approach and the life course approach. And then also that maybe we should think like if we invest on case management on pneumonia and diarrhea and then the malaria, how could this actually improve the care, not only for child, but for the newborn as well? And then also maybe we could use this system to follow up development of the child, or maybe we can tackle the mental health of the mothers while the community health workers tackling these problems and so on, so that we have to maybe think out of the box to how could use this synergy dependence of the care and interventions to bring the care closer with quality without overwhelming the community health workers and then the health systems. Over.
Thanks, Tomomi. So, and Tomomi, I'll request you to stay online a little bit, but later we'll be having a plenary session and there could be some more questions that you need to respond to. But at this point, I want to invite someone who leads the campaign for accelerated reduction of maternal mortality within the African Union Commission, and that is Princess Alleluia Delphine. She works with the Health and Humanitarian Affairs and Social Development Department within the AUC. And as part of this role, I know that she's committed to improving maternal health outcomes across the continent. Now, Alleluia, the question to you, you have seen the data. As a continent, we are the biggest contributors of maternal mortality, but also child mortality globally. So what strategies, and also before I ask the question, we understand that again, the financing landscape is changing, but even at country level, we know there are fiscal pressures at that level. So the question is, what strategic actions should African countries employ to navigate the transitions in ODA, the challenges at country level, in order to prevent the preventable deaths of mothers and children at the lowest level? So I'm going to invite you for a few minutes to share with us what you think from the AU perspective. Over to you, Alleluia.
Thank you so much, Esther. Can you hear me? Am I audible?
Yes.
Yeah, let me start by at least saying that sending my commission greetings, distinguished colleagues, partners, and friends. Warm greetings from the African Union Commission. And we really sincerely thank PAF for this kind invitation to join this conversation. So being with you today to discuss or to reflect on the future of maternal health and child survival in Africa, especially in light of the rapid changing aid landscape. It's a time for us to see it as an opportunity, but also as an urgency. So she had said that I've seen the data, definitely, yes. And over the past 2 decades, Africa has made important progress in reducing maternal and child deaths. And those gains were made possible through bold political commitment, strong partnership, and regional initiatives such as this campaign she highlighted, the strengthened campaign on accelerated reduction of maternal mortality in Africa. However, not also forgetting that the plus of this campaign speaks more about newborn, child, and adolescent. So let us be clear. These gains we are talking about, even the hindrances that we are talking about, are under a serious threat. We have witnessed already a significant shift in the global health financing environment, and where we have noted that traditional donors are reprioritizing and even some are withdrawing. External assistance also for health, which was once a major pillar of support, is no longer guaranteed. So our member states especially are feeling the impact of those official development assistance transition. And as the African Union, what do we see? Are we wishing to see it as a trade only, or do we wish to see it also as an opportunity to act? So we want to reimagine and reinforce our African-led system that can sustain or accelerate progress towards 2030 and beyond actions around maternal, newborn, and child health, MNCH. So let me just outline a few actions or strategic action we look forward to in terms of moving forward. We need to see our member states prioritize health in their national budget in line with the Abuja, what we call Abuja Declaration and the African Scorecard on domestic financing. But also this means that we need to move from theoretical commitments to actual budgeting allocation, particularly for reproductive, maternal, newborn, and child, and even without forgetting adolescent health. So we also must keep maternal and child survivor on high political agenda. Yeah, this is our duty, not just in ministries of health, but also in cabinets and parliaments, I would say. Even without forgetting these finance ministries. And also using our instruments such as scorecards, we need to ensure that we are tracking progress, ensuring that our shining light is on success and through these demands. Looking to data also. Data must serve our priority, not just as in donor requirements. We shall strengthen our member state systems to guide in planning, even informing budgets. And this will help us be able to drive targeted interventions for women, especially, and children in fragile and remote settings. Noting again that our continent does not lack solutions. We only want to put the solutions on scale. It is proven that we have some even innovations. So we have the task to shift to different things that are working for our continent, especially like shifting to community health focus, mobile health platforms, maternal waiting homes. Those things must be supported and adapted across our contexts. Looking forward to, or without forgetting, the South collaboration as a key platform. And also noting that this campaign, the Calma Plus campaign, not only align with the South to South collaboration, and using our reproductive, maternal, newborn, and child and adolescent health technical advisory committee as a platform to advocate at a higher level on what is needed and what can work. So this will enable our country to share their works and replicate successes. So partnership is very, very important here. We can't do anything without our partners, and rethinking partnership beyond traditional aid is very important. So in this new landscape, we must build equitable partnership rooted in mutual respects, African ownership, and long-term sustainability. We must also tap into non-traditional sources. So we have seen that African philanthropy, diaspora engagement, impact, those are most of the partnership that helps in closing some gaps. So securing them then in the future for our mothers and children is so important. Yeah. I would want us to just note that even the Sustainable Development goals are ending in less than 6 months. We are in June now, and the remaining half of the year. So, but this doesn't have to make us afraid. I would say we need to ensure we collaborate and we put effort into collaboration, at least to protect and build on what has been our progress. Looking at the data, we really need to protect what has been done and ensure we are also putting much effort in what is remaining. So I would want to maybe conclude saying that maternal and child survivor is not only a technical issue. It is a political imperative. That is why the African Union put so much efforts in advocacy at a higher level. And we appreciate reflecting on our values, our leadership, our vision for the next generation of the Africans. So as a call, I would want to call everyone here present to this discussion to let us work together to ensure that our women, to ensure that we have better reproductive health for women, children, newborn children and adolescents. And we ensure that no one is left behind to give them a chance to survive, thrive, and transform. Not only their life, but our continent as well. So on our behalf of the African Union Commission, I really reaffirm our commitment working hand in hand with member states, partners, communities to build resilient and resilient health system for Africa. So let us move from just dialogues to determination and from commitment to collective actions. I thank you. Thank you, Esther. Over.
Thanks. Thank you so much, Princess Alleluia. Thank you also for reminding us about the need for African countries to prioritize health in their domestic budgets. And of course, linking that to a critical commitment that was made in 2001, which we're referring to as the Abuja Declaration, 15% allocation to the health sector. Definitely that will go a long way in ending these preventable deaths. But also making sure that maternal and child health remains on the political agenda is important, and also tracking progress. So thank you for bringing in the angle of accountability, in these conversations, because we are not short of commitments. But the question is, how do we translate the commitments into tangible action so that we can save more lives for mothers and children? But from the chat, I have also seen conversations about human resources. And there's a question for you, but I will come back to that in the plenary. So Princess, if you could stay with us just a bit so that you can respond to the question of human resources and what we can do as the African continent to ensure that we have, the qualified cadres with the right attitude to serve more women in the region. And within the human resources, I also see quite a number of questions around midwives as one of those critical cadres that we need to think about. So stay with us, you'll come back and respond to that question. But at this time, I want to invite somebody from the community. And because many times when we talk about these numbers, it's easy for us to say, 70% of maternal mortality is contributed to by the African continent. But we forget that behind the numbers, behind the statistics, are actual people with names, are actual children with faces, are actual, families that are struggling and suffering the realities. So I want to invite Nokululeko Shibula. She is, a passionate parents' voice advocate for respectful, culturally sensitive parents' care. And she is also the founder of Umzanyana Birth Services. And Nokululeko, you'll forgive me if I butchered that, but she's running a nonprofit in South Africa that supports women through childbirth and bereavement. And she has gone through some of these experiences herself, and she has turned that into, new energy and passion to support other women like her that suffer stigma surrounding stillbirth and child loss in African culture. So Nukululeko, I want to invite you in just a few minutes to share your experience, but also as a community person, as a community member, what is your vision? What do you want to see done differently at the community in terms of service provision for women and children at the community level? Just paint for us that picture. Over to you, Nokululeko, if you can hear me.
Greetings all, my name is Nonkululeko Shibula. Can you hear me?
Yes, we can hear you well. Please go ahead.
Okay. Thank you. So I am a mom. Years ago, I delivered a stillborn baby. I didn't know there was such a thing called a stillbirth until it happened to me. And this inspired a lot because from the time I was pregnant, I attended all my maternal classes, my antenatal classes. They were called classes, but they were basically checkup. And we spent, as mothers, we would spend a lot of time at the clinic waiting to be checked. And you would find that we're not provided with the necessities. So if some of us will not have the financial means to actually have food and water before our checkups. And up until the last month, which is the 9th month, I woke up one day in the middle of the night and baby was not moving. So we went to the facility, the healthcare facility, the hospital. There was a huge communication barrier that remained a huge question within me, because the nurses will speak among themselves and not speak to me, up until they took me to a doctor to confirm that baby's no more. And I was alone at that time. No family member was called. No companionship, no support was called into the room. I was taken to an isolation ward where I was then isolated with minimum care or attention provided to me. That includes pain medication as well. And the entire process was traumatic and unbearable. I gave birth on Friday and I had to remain at the hospital 2 more days the weekend, because social workers do not work on weekends. A social worker came in on Monday, and because it was too soon, I could not remember what the social worker was saying in terms of counseling and communication. So my experience led me to then go ahead and research and find out what is it that's been done for mothers who have experienced stillbirths, and to as a follow-up, following up on them, because I figured things on my own, and that led me to then decide, you know what, let me just replace the pregnancy with another pregnancy. And I developed anxiety, and I went to the hospital. I started my antenatals later on, which is 6 months in the pregnancy, because of the fear and the experience that I had received previously on my first pregnancy. And that did not stop me though, because I started gaining knowledge, and then I gained my certifications, and then that's how Umzanyana was born. So what could be done within the community to address such issues is train the healthcare workers to provide care with empathy and presence and respect, support mothers emotionally as well as mentally, establish bereavement care protocols within the healthcare space, follow-up visits, which are proper in counseling access, which is thorough. So improved antenatal education, not just checkups, but proper education. Tell me when baby is not moving, or when the fetal movements are less, that means you need to go and get checked. There might be something wrong. Improve communication, follow-ups. So if a mom comes in and mom has a history, there needs to be a way where a mom is remembered and checked of micromanaged such things. So I believe the story would have been different if maybe the empathetic and respect care was given, and our mothers are provided or empowered at vulnerable moments such as this. Communication was thorough. And if I had known, some of the information that I was left to figure out on my own, and also good communication builds trust and improves coordination. So it builds trust that even from the first week of pregnancy or the early stages, the first trimester, I know I need to go and get checked. I know that, but because there was no communication or relationship or rapport that is built between the healthcare workers and the community, we decide to do otherwise, and that affects the experience and the numbers. So that's why Umzanyana was then found, because we saw the gaps in empathetic and respectful care, and we saw that there was a huge gap in maternal health education and companionship, which is very limited in our communities, as well as support, that is peer-to-peer support groups and supports in general, in the staff, in healthcare workers, clinicians. So we believe that every mother deserves to be held, heard, and honored, whether she brings life or a mom is grieving loss. So our mission is to bring compassion, dignity in childbirth, and continuity into maternal health spaces and systems. So no mother walks the journey alone, and all mothers are educated, supported, and empowered to give birth to their healthy bundle of babies. I thank you.
Oh, thank you. Thank you so much, Nokululeko, for being so vulnerable and sharing your story with us. I can see some love emojis. If you could send a lot more of those, but just some love from across the African continent. But thank you also for turning that into something positive, that you're able to help other mothers. So a lot of love from across the African continent. So at this point, I want to invite Dr. Samuel Oyeniyi from Nigeria, who heads the Reproductive Health Division within the Federal Ministry of Health and Social Welfare in Nigeria, and is also the Secretary, National Reproductive Health Technical Working Group. And you have served, Dr. Oyeniyi, you have worked in the Department of Public Health and Family Health for more than 20 years. But right now you are providing oversight in terms of how these outcomes can be improved, especially in a country like Nigeria, which also has very high maternal mortality rates and also child mortality rates. So my question to you, Doctor, is how are you thinking about financing MNCH within the context of Nigeria, given the shift in the financing architecture, but also how are you providing guidance to the subnational levels, because you work within a decentralized setting? So what guidance are you also providing to the subnational or the state level to be able to respond to the challenges that they have at hand? And just to share a bit what the innovations that you're focusing on look like, so that we can start changing the statistics for the African region. Dr. Oyeniyi, if you can hear me, I want to invite you right now to share your remarks.
Good afternoon, everyone. I didn't hear the initial part of the question. I don't know if it's something, if you are hearing me, if it's something
yes,
that you
can hear you.
Okay, if it's something you can quickly go over the first part of the question so that I can take it again.
Thanks. So my question to you, Doctor, is that as someone who is providing oversight to the MNCH program in Nigeria, in light of the recent shifts in the funding architecture, what measures and innovations are you implementing at national level and subnational level to ensure that you sustain services for MNCH in Nigeria, and also both at the national level, but also at the state level? What are the innovations? How are you financing, and how are you responding to the current shift?
Okay, thank you very much. Based on the current situation, Nigeria has responded very well to the current shifts. When these shifts happened, His Excellency, the President of Nigeria, President Ahmed Tinubu, approved for all the agencies to come together, and submissions were made. And he was able to approve the release of some fund to fill few gaps initially because of this current change that has happened. But on a sustainable part of it, in terms of the subnational, you are aware, to those that are not aware, health in Nigeria is in concurrent list, which means the subnational level, they have few autonomy to make impact and do some things as per their health, take decision, but guided by the national. And they have to put everything into consideration in doing that by adopting or adapting what the national has developed for the state. So that dichotomy that seriously make an impact on the progress that we need to do. And that's why for us, coordination advocacy is number one, to be able to make impact at the subnational level. And for us to do that, the first thing for sustainable impact is to create a structure at the subnational level that are not there for MNCH. And that structure is the creation of Department of Family Health at the subnational level. Out of 36 plus FCT, we'll be able to create or establish Department of Family Health in 8 of the 37 states, as it were. But we are making progress to do this. Apart from that, the Honorable Minister, His Excellency Ali Pate, made the governor to sign an impact so that it will make it easy for them to implement based on evidence-based guideline policy that we have developed from the national level. So that's an innovation to be able to bridge the gap of the dichotomy in the Constitution, so that once at national level we are able to make an intervention, the state, the subnational, will be able to implement based on that impact signed by all the governors for us. And that has helped us in facilitating a lot of intervention at the subnational level. The second thing is health insurance. We've been able to scale up health insurance. Enrollment for health insurance has increased in Nigeria from the community, so that they can have access because of these shifts that we have. So, and apart from that, the national health insurance agencies are conducting free surgery as we are speaking, and about 4,000 free cesarean sections has been done so far to make that effort at the subnational level. And they are also doing, we call it obstetric fistula repair, also free at the subnational level. So health insurance has been strengthened for the people within the country to be able to have access because of this shift that we have. Another thing that we also make possible for those at the subnational level is the creation of SWAP. SWAP is a sector-wide approach, which is meant to coordinate activities, both at the subnational and national level, so that implementation can be seamless. And we have developed, we've created 7 TWGs looking into health workforce. We all know the issues about migration now, so that they can look into that. And we also have the M&E SWAP TWG. We have the RAMCA SWAP TWG. All these TWG are coordinating the relationship in terms of implementation by the subnational and the national, so that we can have a better impact. There is another innovations that we did, which is we call it PIFAC. PVAC is a value chain, unlocking the value chain within the system, the health system, and they focus on local production of items, commodities. So looking at what is already shifting, there is a need to look inward. And for Nigeria, the present minister is already doing that. With the establishment of PVAC, we are looking inward, how we can begin to produce some of these essential commodities in country. We have gone very far in this, and one of those is the production of a calibrated drip in country. You all know calibrated drip is very important to estimate blood loss after delivery. So if you look at it, we have been using factual estimation before now. And that factual estimation, a lot of wrong estimates are made. The uterotonics, there are some of them that are for preventive, some are for treatment. So the blood loss will have passed the pph level, and some will still be given the preventive measure because the estimation is wrong. So the minister, the coordinating minister, pronounced that we should stop the factual estimation of blood loss and be able to use calibrated drip. And we have rolled out policy guidelines. We've developed technical specifications for calibrated drip. So we have 2 companies that are producing calibrated drip in country now that we've started using in country by all the 3 healthcare levels to estimate blood loss, and they are being trained. Facility healthcare provider are being trained, and with that, we'll be able to stop postpartum memory as a major cause of maternal and newborn death in Nigeria. Apart from that, there is another we call National Emergency Transport System, which also is one of the innovations that was established to cater for access to healthcare from remote area, that mothers, newborn that are sick can be moved to facility as much as possible. So when we look at it, these are the innovations. We also established what we call maternal and neonatal mortality reduction innovations. This is an initiative where we look at high burden local government area in terms of maternal and newborn deaths, and they are focused on those areas. We have 172 local government areas where we have high burden. So those areas are being focused on looking at inwards funding from government. And when we do that, we now look at interventions, accelerated interventions that can quickly bring maternal and newborn death down. And those interventions are now focused on the 172 local government, and they are found in 33 states of Nigeria. So with that focus and focusing on this LGA, it has helped us to now put all those interventions and see how we can reduce maternal mortality based on whatever we have to do this in terms of what we are facing now in terms of financial crisis. So, and also even the regular budget has been looked into presently, and more financing is going into it in terms of budgeting for commodities and others. So these are the things that we're doing. I don't know if I still have more time.
You have just 30 seconds.
Okay, 30 seconds. So concerning the capacity building, I want to say a little about the capacity building and commodities. I've mentioned that we are at the verge of producing some of these commodities in country, which we have already started. In terms of capacity building, we're also looking at how can we put most of these curriculum into the curriculum of health workers, which we have done for the nurses and midwifery, for Medical and Dental Council. And we are looking at how we can streamline in-service training to be competency-based so that we can have more of bedside teaching. We can be able to have champions at the facility that will continually train health workers to deliver quality health care. So these are things that we have been able to do. We're also doing digital capacity building, which we are moving into. There are 2 of those digital capacity building that we are already proposing, and it's on the high. We have planned very high now, where we are going to have modules in the cloud. Students, health workers will upload them on their phone, and the demonstrations will be there that people can go there to look at these procedures and improve quality of care and service delivery at the health facility. So because of time, these are few of those innovations that we'll be able to put in place because of the financial crisis that we have. Thank you.
Thank you. Thank you so much, Dr. Oyeniyi, for the insights that you have shared, but also especially, just the interest around the innovations that you have introduced, that you're looking at scaling up. I like the PVAC. I love the calibrated rep that you have talked about, and making sure that there's local production so that you reduce the costs. But also thinking about the national health insurance. I know quite a number of countries in the region are thinking about what that could look like in their context so that, we increase universal coverage. So I'm excited that Nigeria has already started implementing these. But there is a question for you that I'll invite you back to respond to a bit later. And it's someone is asking about the coordination of resources, especially the donor coordination. They're asking, Nigeria is one of the countries that has been listed as one of the priority countries for the Beginnings Fund. I also see you also a GFF, of course, beneficiary country. So how are you coordinating the opportunities that are coming up, the additional resources that are coming in the country in a way that responds to where there's critical need? Because from your presentation, you've already mapped out those areas where there are gaps and what you need to do differently. So we'll come back to you and you respond to that question. And so allow me to invite our last speaker for this afternoon or this morning, depending on where you're joining us from. And I want to invite Iyaduni Olubode. Iyaduni, you'll forgive me if I have butchered your name, but she's the program lead for MSD for Mothers in Kenya and for the Kenya and Nigeria programs. She has over 20 years of experience working across private and development sectors in Nigeria, but she's also a fierce advocate for women and youth as key contributors to the economy. And Iyaduni, would like you to talk to us about the key partnerships that are critical for improving access, especially now that we have the shifts in financing. So what are how should we think about partnerships to ensure that we are driving change, but also, we are doing that in a way that is sustainable and scalable so that we end these preventable deaths? If you can hear me, I want to hand over to you.
Thank you very much, Esther, and thank you, Dr. Oyeniyi. It's a pleasure to see you on this call. Thank you to all our amazing speakers who have done an excellent job of setting the context. I think now more so than ever, the role that the private sector can play in collaboration with the public sector in addressing the health challenges broadly, but in particular, we're speaking about MNCH, is the case for public-private collaboration is well established. We understand the challenges with financing that the government, many governments are constrained in terms of the financing that's available for health. We know that private sector brings innovation, they bring technical expertise, and they bring access. And another way that you can talk about access is trust. We have statistics that demonstrate, at least in Nigeria, that more people are seeking care in private healthcare facilities, and that over 70%, I think the most recent on WHO website is showing that as high as 78% of the spending in health is coming from private sector. And so it's a no-brainer, especially in this current climate, that public-private collaborations, and I'm using the word collaborations because we need to think broadly about how we work with each other, is critical. I think that having universal health coverage, if we're serious about achieving the sustainable development goals that have been articulated, then public-private collaboration is critical. Now, in terms of partnerships and models for partnership, there's so many collaborations that we have been a part of and that we've seen. For example, in Nigeria, one of the efforts that MSD for Mothers, and MSD is a pharmaceutical company, MSD for Mothers, the organization that I represent, is an initiative of that pharmaceutical company focused on improving maternal health outcomes globally. Nigeria is one of 4 focus countries, as is Kenya. One of the innovations and one of the bright spots that I think that really point to the potential for private sector and public sector coming together to make a huge dent in this challenge of maternal and neonatal mortality is the innovation around PPH. Dr. Samuel Oyeni has already alluded to this, but MSD for Mothers has been at the forefront of engaging with organizations. When we began this journey about 12 years ago, PPH was and still is the primary killer of pregnant women. And so looking at PPH and trying to better understand what the issues around PPH were was one of the things that we did. And so in understanding those issues, we identified that there was a challenge with the gold standard, oxytocin. The challenge being that oxytocin needs to be kept at a certain temperature for it to be to maintain its efficacy. And in our part of the world where the weather is quite warm and power is a challenge, that led to the quality of oxytocin on shelves in hospitals. Based on a study that was done by USP, they were able to demonstrate that a lot of that oxytocin, I believe it was about 74% of the oxytocin on shelves had deteriorated in quality because it hadn't been transported in cold chain. It wasn't being stored in cold chain. And so looking around, we did identify another pharmaceutical company that had created a heat-stable medicine that could be used for prevention. This is a private sector organization. We are also a private sector organization. And so we entered into a 3-way agreement with the WHO, a tripartite agreement between MSD for Mothers, MSD through MSD for Mothers, WHO, and Ferrin Pharmaceuticals, who is the company that manufactures this medicine that has potential to address this heat sensitivity. And because we are in that partnership, WHO is able to take these medicines, engage with our support in a clinical trial involving women from Nigeria and Kenya and a number of other countries, establish its non-inferiority. It was on this basis, on the basis of this evidence, that they were able to update their recommendations. And so I'm using this example to highlight the value of these partnerships. There's so many of these partnerships, but why haven't they scaled? And I think that this is the conversation that is most critical, because we've talked about the value that private sector brings. And this is where I think we need to spend a lot of our time thinking through, is we need to be able to work with the government from the beginning, understanding what their challenges are, understanding what their priorities are, should be government-led, should be data-driven. What is the data showing us? What is the evidence? Should be affordable, what we're designing should be affordable by governments. Now, cost effectiveness is not enough. We need to be able to answer the question, how much does it cost to offer this solution to my people? Because if government is going to pay for it, it needs to fit into government budgets. It needs to be collaborative. And this is where I say you build on existing solutions, you collaborate with other people, bring more people around the table so that you are able to get more support to scale solutions. I think if you went to the Global Digital Health Conference, you would find so many solutions that could address challenges in maternal health and neonatal health. Why are they not being taken up? I think if you look at these reasons, we will see why. I think we need to do better with engaging with the government. We need to do better with working with each other, and we need to do better with designing solutions that are not just cost effective, but are affordable by the governments that we're looking to partner with. Thank you, Esther.
Thanks. Thank you. Thank you so much, Iyadunni, for reminding us that the partnerships are important, but when we think about solutions, they need to be government-led, they need to be data-driven, they need to be cost-effective. And so coming up with the solutions, it also needs to be a collaborative effort. So thank you so much for that. And the interesting example you shared there of oxytocin and how you work to navigate some of the challenges that you're facing in Nigeria. So at this point, I want to come back to the plenary and ask if there are any questions, or comments. And I'm going to give each of the speakers just one. Let me give you 30 seconds. Let me give you 30 seconds to respond to the questions. I want to start with Dr. Oyeniyi. That was a question about how the donor coordination, because all those are part of the accountability efforts in terms of the resources that are coming in the country. In 1 minute, how are you as Nigeria managing to coordinate and bring the efforts together so that the investment responds to the most critical need in the country? Doctor, in 30 seconds.
There is an innovation around the health sector renewal investment initiative where we have the term one coordination, one budget, one conversation, and one plan. So when this came up, all the partners and governments, we are now putting our efforts together into one plan and into one coordination. And in the coordination is divided into about 7 TWGs. And one of them that is majorly for maternal and newborn, we call it RAMCA sub-TWG. So partners are now coordinated into one coordination. And for fund based on the plan that all of us has agreed to, the funding is now being used based on priorities for the people of Nigerians. So thank you. Since I have 30 seconds, I don't know if I've been able to answer that questions, but that is the coordination.
Yes, definitely. One plan, one report, coordination, that is important. So thank you so much, Doctor. I now want to introduce a Menti session, and we will have just maybe 2 or 3 minutes to respond to the questions there. And the question we are asking is around accountability. Commitments have been made. Financing has been committed. Policy commitments have been made by national leaders, by regional leaders, the African Union Commission, and all the leaders at different levels. So I want to request us to go to that Menti. Just type into your gadget www.menti.com, enter in that code, and there's a question about what strategies we need to employ to drive accountability efforts in the region. As Africa, we are not short of commitments. We have those in plenty, but the question is, how do we ensure that the commitments that have been made are actually actualized? So I want us to just spend a minute or two and share our thinking around how we make that happen. How do we make sure that the commitments made at regional level, at national level, even at subnational level are actually actualized? So I want us to spend just a minute thinking through that, because it is critical for us as a region to think about that. The national budgets that were read in June across the African region are also another commitment to the people. So how do we ensure that we have the commitments made, but we also have them implemented? We hold the leaders accountable. How should we do that? And I'll be sharing with you some of the responses that are coming in, but please just feel free to share that again. Somebody's asking for the code. If we could have the code in the chat, but also actually the code is on the screen. So please feel free to go there. The code is available on the screen, and just share your ideas about how we hold ourselves accountable. Okay, great. I see quite a bit of emphasis on data. Data is important. So what progress are we making? We need to know that if we have committed to increasing financing, are we progressing? We need to have the evidence to tell us where we are. So further finance women's health research and innovation to better collect data on maternal health conditions, and also find solutions to PPH and preeclampsia. Great. We need to develop action trackers on the commitments, make commitments known to technical teams, political leaders, and NGOs. Okay. Any other ideas? Invest in research and development on maternal health for sustainability. Improve communication, so progress is not lost when leadership changes. Okay. Health surveys on women and children to find out the level of their health status. And then strengthen health systems to look at quality as defined by users and providers. Okay, thank you. Thank you. Please keep those coming in. Keep those coming in. All grants and loans given to African countries should have really strict conditions. Okay. I hope somebody from the Beginnings Fund is reading that, and also GFF. Have local level accountability mechanisms. Okay. Okay, please keep those coming in. I know we have just 2 minutes before we close. And so I want to invite my colleague, Wanjiku Manguyu. I want to invite you, Wanjiku, to close us off and share the last remarks, the closing remarks. So I want to hand over to you.
Thank you. Confirming you can hear me?
Yes, we can.
Okay, great. Thank you, everybody. We've come to the end of this webinar, and I'm really happy to be able to express my gratitude, not only to the speakers, to the wonderful speakers that we've had, but also to all of you who have attended and participated and are continuing to share your thoughts over the chat and have contributed to this discussion. So thank you very much. So in just the last 2 minutes, we've in terms of sort of some closing remarks and reflections, we've had some really powerful insights. Data shared by UNICEF really highlights that both the progress has been made, but that there is urgent need to accelerate efforts to meet our targets. I think that is the one thing that has really come through from that data. So we need to do more. We need to do it differently, and we need to do it now. What's clear is this: the future of maternal and child survival in Africa cannot be left to chance. It must be shaped with intention. It must be through collaboration and with bold action. So at the heart of this effort is advocacy, and I was glad to hear, I think, all speakers reference advocacy at one point or another. And that's why PATH, together with our partners, is advancing a united advocacy strategy for maternal health and child survival in Africa. So we're trying to move from commitment to action. And this is not just a document, it's a tool for driving coordinated and impactful action. It lays out some clear priorities, including securing increased domestic financing for MNCH, particularly in this current and ongoing context of shifting external funding and global funding. So another is keeping the health of women and children firmly on political agendas. So ensuring it remains a central priority for all our leaders. We're also looking at innovatively advancing accountability. This is for all the resources and policy commitments made, as highlighted in the chat and in the comments that are coming through. Integrating MNCH into broader health and development frameworks, including, universal health coverage and primary healthcare reforms. Strengthening data and evidence to build a compelling case for sustainable investment. And then finally, looking at cultivating and supporting national and subnational champions, one of whom you heard earlier on today. Champions from civil society to parliamentarians, to all of us, to ensure that we're driving results. So strategy is only as strong as the movement behind it. So now more than ever, we must strengthen the advocacy momentum across our region, across the African region. As our funding priorities shifts, Africa must lead its own response. So that means building political will, demanding accountability, and amplifying the voices of our women and our children and our communities who are too often left out in decision-making. So this is not a time to retreat. It is a time to reimagine, to re-energize, and to recommit. So let's leave today's dialogue, with conviction, ready to act. Let's work together to ensure that every woman survives childbirth, every newborn lives, and every child thrives beyond their 5th birthday. And also that every country can sustain this progress, regardless of the aid landscape. So once again, thank you so much for your commitment. Thank you for walking this journey with us. We look forward to part 2 of this important conversation coming up in the next few weeks. Thank you very much for being with us.